I went to my first rotation. It was in the hospital. And there was this patient back then. They were in a cell by themselves, and it was screaming and yelling, very psychotic. He got a shot, and he was perfectly normal. And I was like, I can just not believe this. Somebody so sick gets this medication, or their behavior completely changes. So that started really my journey in psychiatry.
Welcome to Evening Rounds, a podcast that takes you behind the scenes in medicine. Tonight, we have Dr. Carolina Osorio. She's a psychiatrist that manages some of the most difficult psychiatric disorders. During our interview, she shares with us the power of gratitude and the importance of personal time, and how both of these things can impact your optimal mental health. Well, Carolina, we're really excited to have you tonight on our Evening Rounds podcast. We're going to get into all sorts of great conversations this evening. I wanted to ask you, when you were growing up, did you ever see yourself living in Southern California?
Never. First of all, I promised myself I will never live in a country or a city or a state, whatever, where there was earthquakes. So I jinxed myself.
Oh, no.
Yes.
No, where is your home country? Where are you from?
So my home country is Colombia in South America. I always want to make sure it's with an O, not a U.
Colombia.
Colombia. Yes.
All right.
I'm gonna remember that from now on, anytime I pronounce it, and be a little bit nervous about it. Tell us how growing up in Colombia was.
As a child, I have these really amazing memories. I live in a community that was gated, and we were very free spirit. Everybody was playing outdoors, hiding in the bushes, jumping from trees. It was amazing. Lots of friends. I grew up in the same community, until I literally left. And it was just very free spirited, very nature oriented. So
you knew your neighbors?
Every day we will go, hey, can I borrow sugar from you?
Wow.
Yeah, very much so.
That sounds idyllic. That sounds perfect.
It was really nice.
See, that's very interesting. I, from the news here, and think of Colombia in a different way, but it's really awesome to hear your perceptions. And I mean, you lived it, obviously. You grew up in Colombia, because we hear on the news about, drugs and crime and things like this. And it sounds like that wasn't the world you knew there.
Well, so I knew both worlds.
Interesting.
So, yes, there was a lot of violence. And also there were good things. So, I feel that news are very biased to negativity because that's what sells. But there's always good and bad everywhere.
Did you have any experiences that were less than ideal growing up there?
Yes. I had a couple of them. And the one that probably the one that sticks the most to me is when I was close to 20s. I don't remember exactly. I was going to be kidnapped.
Oh, my.
So that was really scary. There they kidnap people for ransom. So if you are kidnapped, you know that you're going to be tortured and a lot of bad things are going to happen. They may return you to your family or not. They will ask for money. So when that happened, and my friend was dropping me home, so these guys came with guns and they, pointed at us, and then we got out of the car. And when the guy said, go in the car, I knew in that moment I was not going in the car. So, but God had plans for me. So here I am. Yeah.
That's amazing.
What a hard decision in that moment.
Yeah. That's why I always say people don't know how they're going to react until they are faced with the circumstances.
Yeah.
Yeah.
So you were in your 20s, you said there. So you did a lot of all of your formal education in Colombia, is that right?
Yes, I did. So in Colombia, you finish high school and you go directly to med school. There's no college or anything.
Wow. That's a huge commitment to knowing what you want to do that young.
So you need to know right out of the bat. Yeah.
Well, I would have not been doing medicine then.
Yeah,
I had
right?
no clue what I wanted to do when I was in high school. So what inspired you to become a physician, knowing that early on in life, that's what you wanted to do?
I don't really have a great answer for that question. I only know that I always wanted to be a doctor. I think in part, I always wanted to be of service. And I think back then, that was my number one thing that I thought I could really be used, to serve others.
So what brought you to America?
Well, it's a combination. So basically safety and opportunity. So what happened to me was the last year. I think after that happened to me, I stayed one extra year in Colombia, and then I came here. Things were not good there back then. And then, United States is an incredible place for opportunity. I think anyone can really go as far as you want here. Those are opportunities you don't see in third world countries.
We focus a lot on what's not right here in the United States.
I know, exactly. I'm a very big fan. I cheer up for the United States all the time.
So when you talk to us a little bit about that. So the land of opportunity, we hear that and we see Staten Island and things like this, right? But when you're coming to America and you think about the opportunities, break that down a little bit for us. What do you mean by that?
Yeah, so it was no instance it was an easy process. It was very difficult. There was a lot of sacrifices made. But if you persevere and you stick to your dreams, you can go really far. It's like, just look at people that are so famous, like Snoop Dogg, right? He came from Compton and he is now makes millions. So you really can't, that doesn't happen in my country because there's no resources that you can do that. Even in Colombia, doctors don't have the standard of living that doctors have here in the United States. Even though you might be very perseverant, maybe you have the passion, the desire, the resources are not there for you to really go as far as you really want to go. And so here in America, you do have that.
So as you were seeking the opportunities that were afforded to you that you worked hard to achieve, how did you end up in psychiatry?
Well, that I knew from med school.
Okay.
So the first seed planted to me was back in basic science. I was studying human development. And so for me, seeing these little baby milestones was wow, impressive, amazing. And I was like, wow, the brain is so beautiful that all of us, we go through the same milestones. Nobody teaches us those things. And so one of the homeworks that I was assigned is I needed to do a little video of a child completing their milestones. So my friend had a good friend, my mother had a good friend and her daughter was 2 years old. So I spent a whole weekend recording her doing different skills that I knew a 2-year-old should be doing. And so that really inspired me, and I just love that aspect. And then when I did my rotations in psychiatry, I remember very clearly till today, I went to my first rotation. It was in the hospital, and there was this patient. Back then, they were in a cell by themselves, and it was screaming and yelling, very psychotic. He got a shot, and he was perfectly normal. And I was like, I can just not believe this. Somebody's so sick. Gets this medication or their behavior completely changes. So that started really my journey in psychiatry. So when I came here, really God has a plan for you. I had this amazing opportunity to come to California to volunteer in research at USC doing schizophrenia trials. Wow. And so that's my first step here into the ability of, really going into residency.
And what brought you then to Loma Linda?
So that's another story. When I was studying for my board, so I worked for a while, then I took about a year and a half off, and I just literally took step 1, 2, 3 oral, one after another. So I took a lot of courses and classes, and during that time, I met a friend, and her name was Christine. She was from the Philippines, so we both were studying for the exams, and she was Adventist from Philippines here. And she and I were studying, and she said something like, well, you should apply to Loma Linda. And I'm like, what's Loma Linda? I don't know. And then I started doing research in Loma Linda and all that, and that's how I came to know where Loma Linda was and what was the mission, the purpose. And I applied, and then I matched here.
That's cool. So I remember as a third year, maybe fourth year medical student, I did a rotation in an inpatient psych service, and it was amazing. I remember the psychiatrist sitting me down and saying, now, Anthony, you're going to do the intake exam on this patient, but you have to sit between the patient and the door. You can't have the patient. I'm like, holy buckets, we're doing some real stuff here today. And the patient was schizophrenic and accused me of trying to poison them with this and the like. And I was so fascinated by the brain. I was fascinated by psychopharmacology. And I know you work in some pretty intense situations. And I'd just like to hear your perspective on what you see as the biggest challenges right now to treating people who are suffering with mental illness. Simple question.
Yeah.
Very much.
Yeah.
Well, so in my opinion, I think that the biggest obstacle is the lack of resources. So you would think, for example, that someone who has a severe mental illness will need more than just medications, right? And for most of what we have as physicians is the ability of prescribe medications, but we don't have the ability to prescribe things like vocational rehabilitation because there's no insurance that's going to cover for that. And what these individuals need is medications plus vocational rehabilitation plus social support and so many other things that they don't have. A lot of our severe mental ill patients, they also have comorbid substance use. And there is absolutely no treatment for them. So for example, I used to work at SAC, and we had a clinic there, and we had a lot of patients with substance use, but we don't have partial programs there. Partials that we have here at the BMC, and they're proven to be very effective to maintain sobriety longer. And we didn't have them just because the insurance, they don't cover those services. And so it was really heartbreaking. I mean, what am I going to do? I'm going to tell you that you have an addiction and that you need to stop using drugs? That's really not very effective.
So sort of the incomplete, comprehensive treatment program that a lot of the patients you see will need, society doesn't provide really at this time.
No. Yeah.
I know you see a lot of really violent mentally ill patients. Obviously, that has to kind of break your heart seeing how we have a solution or a potential solution. Do you see those as obviously all being linked then?
Yeah, so I also work at Patton State Hospital, which is one of I think the largest forensic hospital in the whole nation. We have 1,500 beds. And so there, I work in a unit that is a competency unit. So patients come from jail because they're unable to stand in court because they're so ill, right? So they're hallucinating, they're not cooperating with their lawyers, they cannot behave at court, so they end in Patton, and we bring them back to competency. And
hold on. You bring them back to competency.
Yes.
All right. Keep going with your thought, but I'm going to have to come back to that because I'm intrigued by how you bring someone back to competency.
Okay. Sounds like a plan. So they come, right? So a lot of them, I divide my patients in 3 categories. Those ones with severe mental illness, a substance use disorder, and antisocial personality disorder. That's also within the spectrum of psychopathy. Then you have those ones who have only a severe mental illness with or without substance use. And then you have those who are only antisocial. They have psychopathy. So we can treat the mental disorder, we can treat the addiction, but the antisocial personality, in general, you want to think there is really not real good treatment for them. They're just people who, by definition, lack empathy. And so there is no ability for them to really feel any kind of regard to other people. And so those are the really difficult and dangerous patients. But those are really very rare. And usually when they get to Patton is because they're sometimes, pretending to have a mental illness, but we're very good at peeking at that. And then they go back to court and jail pretty quickly. But most of our patients, I would say, 95, 97%, they really have a mental illness and a substance use. So every patient has a psychiatrist, a psychologist, a social worker, and a recreational therapist. And so we address them through the biopsychosocial, spectrum to provide them the best treatment that they can possibly have. And of course, they have an internal medicine doctor taking care of the medical side. And we treat their mental illness. They're off drugs, so they get better, right? And many of them, they want to be better. But guess where they're going back? They're going back to jail. And from jail, they go back on the streets. They end being homeless. And it's this vicious cycle. So a year or so come again, they end back in the hospital.
So you had mentioned that a big component of the patients who you end up caring for with severe mental illness also have substance abuse. Did I catch that correct?
Yeah.
So is it substance abuse or is it addiction? I mean, are these individuals who, if they didn't have the addiction, would have a mental illness that would be readily treated, but with the addiction, it's gotten much worse? Or is it severe mental illness that drives them to the addiction? Is it the chicken or the egg in these situations?
It will always be that question.
Okay.
It is always going to be either the chicken or the egg. It's very hard there are patients that you can see they really have schizophrenia and they're using drugs. But there are a lot of those patients that you're never going to know what happened first or what is what. A lot of them have used so much drugs, they literally have destroyed those synapses.
Gotcha.
Yeah.
And so they end having really very low levels of functioning. They remain psychotic for indefinitely. Medications don't really work as well for them.
Just to follow up on what I said I was coming back to. So it sounded like you had answered that the return to competency really requires a multifaceted approach. And then I want to make sure I understand this correctly. So when they are returned to competency, then they go back to jail.
They go back to court.
They go back to court.
Yes.
And then pending the court judgment, they either are released or go back to jail.
Correct.
And then they end up back into their original environment, generally speaking.
Homelessness.
And then they come back to jail and are incompetent again, and you are seeing them again at patent, and then it sounds like that's just sort of a perpetual cycle.
That happens, yes.
So, as the expert,
okay,
how do you break that cycle?
Well, we need to have help in the communities. We need to have programs. We need to have ways where we can help them not to fall back into drugs. A lot of them, a very big amount of them, they actually end committing a crime because they are high on drugs. Yeah, and that's a huge problem. But there's no program, there's no long-term structure where they can go to continue their lives within sobriety realms.
That just must be so frustrating. Like, you've worked so hard with this other team to get this person healthy. Where do you find your hope really in this? Or where do you find, that silver lining of, okay, they're back and maybe this one or this time in this broken system that you have to send them back into?
So, we do a lot of debriefing among us. We talk, we process. And at the end of the day, we do the best we can with what we have in a given moment. Because it's all about the present. And this time we help them, they got better, and that's all what we can do. And if they come back, we are going to do the same thing all over again. And then hopefully one day, it rings a bell on them and then something changes. So you can never, ever give up hope, because then that's the end.
Yeah. It's really amazing that you've really kind of built that resiliency.
Definitely.
To such a hard environment and seeing such a really complex set of humans who are really sick.
It really is, yeah.
I wanted to ask your opinion if you have experience in this. There are people who are the receiving end of the patients that you're often taking care of, right? They're the person that experienced that violent crime or that theft or what have you. And I would think a fair number of them have some sort of post-traumatic problem.
Oh, yes.
And they would reach out to a therapist and a psychiatrist to try to help them get through their post-traumatic or to try and achieve post-traumatic recovery.
Yeah.
Talk to us about that process. What do you do when someone comes and is a victim of violent crime and they're seeking your professional help?
Right. So I have been on both sides, right? I have been on the side of treating the person who committed the crime, but I also have been on the side of the person who was the one who received the crime. So I have, patients who have been raped. I have patients who have been victims of domestic violence, all kinds of things you can possibly imagine. And you start just by showing them support and empathy and caring. No agenda. I'm just here for you. I actually have this one patient that I treated at SAC, and I forever will always remember her. So I worked with her for 3 years. And while I was working with her, she was a victim of human trafficking. So thankfully, I had a psychologist working with me at the same time because I could have never been able to do this by myself. So him and I, we were always like debriefing, supporting each other in the process. So she would come, in total major dissociative episode, just had a flashback. It was really bad. And so what happened is that she got pregnant. She was gang raped and she got pregnant. So she didn't know who was the father, nothing. And she decided that she didn't want to have this child. So my job really at that moment was to be with her and hold her hand. There was no other thing I could do. So she said, I'm going to go and have an abortion. She did go and she couldn't do it. So she wanted, but I want to have an abortion. And I told her, okay, I'll give you a medication for anxiety so you can go and have it. And she went again, and she told me that she heard all these women saying things like, take it out of me. And she felt like something so bad, she couldn't do it. So she changed her mind, and she decided to have the baby. And she said, I'm going to have this baby, but I'm going to put it on adoption. So I'm like, I'm here for you. We're going to get this together. And she had her pregnancy. She didn't want to see an OBG because she's so traumatized, right? She has to, have an OBG exam. So what I did and what is beautiful in SAC is that we have a team of OBG, primary care, dental, everything is there. So I walked with her to the OBG office. And so while I was there, she was able to feel good with the OBG, and she eventually built that trust with her. And so she did end having her baby, and she ended actually raising the baby. Wow. She didn't give for adoption. So all this time I'm praying and I'm praying and I'm praying and I'm praying. And though this baby caused her to have a lot of flashbacks, she also loved this baby so much. And I think that was the last thing that finally allowed her to say no more abuse to me and really break out from this trafficking that she was experiencing. I don't think there is like a one specific answer. It's really the process of how do you manage, because each individual is a unique world. Each individual has their own experiences, genetically, nurture versus nature, social support, and imagine everything that makes us as an individual.
It's just such an incredible story. I can't imagine, but I think what's so interesting about that is you really met her where she was. Yeah. And you were there to help her get the care she needed. And if you think about that, like how important it is to have an OB-GYN or how important it is to have that prenatal care, and you're really meeting her there to help her through that. That's whole person care.
Well, it's the ethos of Christianity.
Absolutely, yeah.
That's amazing.
Yeah.
It's hard to even know what to follow up with a story like that.
Yeah.
That's just profound. I did want to ask you how social determinants of health or of disease impact mental health. If you're seeing someone with depression or anxiety and they come from a human trafficking experience, or they are a CEO of a Fortune 500 company who has anxiety and depression, as a psychiatrist, how do you approach, those are two kind of polar extremes, but all the things in the middle as well. There's the DSM-5 criteria, but then there's like the meat and potatoes of it all, right?
So I'm not a very orthodox by me saying what I'm going to say, but I'm not a very big fan of the DSM-5. I kind of feel like it bugs people, in labels. And that I mean, I understand that we have to know those diagnoses. It's part of our training, it's part of being good psychiatrists, but it's not everything because it's far more beyond that. That's why so many, so for example, these patients who end using so much drugs that they damage their brain and they look by the book like a schizophrenic patient. But we don't know they have schizophrenia because this is a drug-induced problem. So what diagnosis based on DSM-5 do you give these patients? So in the very resident attending world, we call them, these patients suffer from methophrenia. So which means patients who have developed schizophrenia secondary to methamphetamines. So that's how our internal lingo is about. And so the DSM-5, I mean, of course, you studied it in and out, and there's actually, on the DSM-5, there is a part where it's like areas for further research, which I was very happy to hear and see, because it feels like they're, opening to a little more than just, having those diagnoses as a label for our patients.
So then you would use that kind of foundation then to approach these patients who are very different in life.
Very different.
Social determinants of health may be stacked against someone versus not.
Exactly.
And then individualize the therapy for those individuals?
Correct. So, the girl who's human trafficked, who really didn't have a place to live. In SAC, I had a lot of females who were currently being victims of domestic violence, and they couldn't leave the situation for some XY reason. So for them to tolerate the abuse, they had to use drugs. So they come here full of anxiety, and I'm supposed to prescribe you a pill and put you a diagnosis when the main issue is that you are in a horrible situation at home with a man who's abusing you. And no amount of medications is going to be able to do much for you. I can give you some palliation, maybe help you sleep.
Wow.
So, yeah, that's, man. I would like to ask you, for the audience listening, if you're going to provide one mental health pearl for all of us to listen and say,
we're giving you all the hard ones today.
If I just do what Dr. Osorio is telling me today, I'm going to be good. I mean, that's a little bit tongue in cheek, but what would be something you would see, man, if this happened in our community for our individuals, mental health would be better?
Network.
Network. Expand on that. Yeah.
Yeah. Find support. Find people that you can reach out for help. Find places that can give you food if you lack of those resources. Find organizations that can help you with housing. Find what you probably are going to struggle down the road with. Some kind of help is out there.
Yeah. That's there's a saying, right? It takes a village.
Yeah.
100%.
And in a way, it kind of sounds a little bit like your neighborhood growing up, where you had neighbor support. Isn't that interesting? Kind of comes back.
So interesting.
Comes back home.
Yeah. So if you want to think about the blue zone, I mean, of course, here, right? What is one thing that is wonderful about Adventist people? You have large communities.
Yeah.
Well, Carolina, I mean, we could go on for hours probably. I can't believe our time is already up for this evening, but I just can't thank you enough. What you do is amazing.
Thank you.
How to stay sane in an insane world seems kind of appropriate for you. But it's just, we thank you and keep fighting the fight, so to speak.
Thank you for having me here.
Thank you so much.